Thank you, Albert, and thank you to Genome Germany for the invitation. I think it's so great to exchange knowledge and that we can work together and we have what I normally say both formal and informal collaboration. So I think that's very important. So thank you for the invitation. So I'm a medical doctor of background. I'm actually a microbiologist. I've been working with genes all my life in different areas. The last 20 years I have been mainly working in leadership, both on at department level, but also at the diagnostic level. And the last 4 years I've been the CEO of the Danish National Genome Center. So that's my background for standing here and for trying to lead this in Denmark and reaching out to you as collaborators. So the Danish initiative was established in order to change the world for the patients and for the benefit of the patients. And just starting with a short story of a cancer patient. This was Tony. He was one of the first patients that had a whole genome sequence. His first and second line treatment didn't work anymore. He had a whole genome sequence done in Jutland at another hospital. And one figured out that there was an experimental treatment at Rigshospitalet in Copenhagen, and he was actually transferred there. It kept his cancer into, its shrink. Of course, he was not cured, but he could have some more years with his family and was actually feeling well, like he said when we interviewed him. So just a list on the left side here for patients in Denmark who are actually now being part of the infrastructure and will benefit for whole genome sequences, and I will get a little bit back to how we have selected them. So it's mainly rare diseases and with an hereditary background, and then it's some selected cancer patients, and I'll get back to that. So the core task for the Danish National Genome Center that was established in 2019 is to implement whole genome sequencing in patient treatment. So in collaboration with the hospital settings, we are implementing whole genome sequences for the benefit of patients. We also collect and store genome data in a secure national infrastructure or database. When the center was established in 2019, we also had a law stating that all whole genomes should be done in a clinical setting should be reported into the Danish National Genome Center. So these genomes we also need to make accessible for medical doctors or for healthcare professionals across Denmark and for researchers and patients. And then our task is also to promote personalized medicine in Denmark. So we were established as an authority under the Ministry of Health at that point, which now is the Ministry of Interior and Health, together with the Danish Health Authority and Danish medical agencies. So, and it was in the law that we should assist the minister in things related to personalized medicines. We should support and develop personalized medicine and run and drive the infrastructure for genome sequencing. In Denmark, we are 5.6 million people, so even less than Sweden, and far less than you. We are probably one of your big cities. So actually the authority is at the national level. So we are a regulatory organization, and the state is negotiating with the regions on the middle side here, and we have 5 regions in Denmark, and those are the ones who are responsible for running hospitals, and then of course the ones who are offering whole genomes for the patients in the patient treatment. Then we have the municipalities that we are not working with at the moment. They are taking care of rehabilitation and nursing. So when we were established, we talk about top-down and bottom-up. It was actually, I think, more a bottom-up initiative from researchers and healthcare professionals that they wanted to have a more firm and way moving forward. So we had a national strategy for personalized medicine for the benefits of patients. which has actually run out here in 2022. But it stated that we needed to establish a national genome center in order to have those whole genomes to be part of developing more precision medicine. I already told you about the law, and another thing that we had is a huge funding from the Novo Nordisk Foundation, 1 billion Danish kroner, in order to actually implement, to build up the infrastructure and to do whole genome sequences, and to have the whole compute facility and to drive it. This funding was made until 24, so we are actually moving towards the end of the funding. And what was decided when we had the funding was that when it ran out, then the state and the regions should take over doing whole genome sequences for the patients. So, and then I will, of course, tell you a little bit about how we are and where we are now. More strategies have come into place, both the life science strategy, working together with industry, so we are also trying to figure out a way to do so, as well as the vision for better use of healthcare data. We have a lot of registries and healthcare data in Denmark, as you have, and one wants to figure out how can we actually use these healthcare data better, both in primary but also in secondary, of course, healthcare. So the way we were established is that we have a steering committee run by the Ministry of Health, and with a head of each of the 5 regions, a medical head of each of the 5 regions, and one representative for the university or the healthcare university, of course, as I'm also part of the steering committee. Then we have some international advisory boards advising us on topics concerning development of the infrastructure and moving personalized medicine forward. We have this both internationally but also nationally, which we call research and infrastructure, as well as you also mentioned, some of you, that patients and citizens and the ethic questions are also important, so that has also been taken into concern. Then we had a close collaboration with technical people. I heard from you as a bioinformatician before, and those people are of course very important, because it's how do we build up the database, how are we actually working, what kind of tools should we work with, and how should the interpretation of all these data actually be aligned, so we make sure that we have a good quality. So we run these groups. And people are assigned to this group from all over Denmark, as well as the societies, the different societies. Then we have the clinical working groups, and the way that the patients are actually selected here is that we have a selection that was actually suggested from clinical staff in Denmark, expert professors, that have selected. And when the patient groups were selected, one of the things that it should have is that it should benefit the patients. Then we again here, specialists was assigned from all over Denmark, or for the 5 regions, as well as from the medical societies. So this is actually how we're running. So we are, as an authority, running these working groups, and then of course we have a head in each of the areas. We have these 17 patient groups, which was also on the first slide. And as you can see here, some of the groups are larger than others. There's a pointer, yeah, there. So for example, neurological diseases, pretty big. We have the immune deficiency, pretty big. And of course we have the rare diseases being a very big group, but that was also the first group, the pilot group we had. And then we have the cancer areas here, and you can see it's advanced and incurable cancers that we're offering. The number in parentheses is what we will get in every month. So of genomes, so we get approximately 1,000 genomes collected into the Danish genome database every month from these patient groups. The way it's financed, we also discussed a little bit by Albert about how do we actually finance. I know you have another system here with the insurance companies, but we have this private fund, I said Novo Nordisk, which have financed pushing it out into healthcare. Then we have an in-kind from the regional resources, and then the Danish National Genome Center is on the national budget. And then if there should be researchers coming in, working in the infrastructure or getting access, they should have funding with them, so they should actually pay for the use of the infrastructure. At the moment, we have a little more than 14,000 genomes in the Danish National Genome Database. We also do RNA, of course, on the somatic samples, and those data we are also collecting. We are at the moment in a process where we try to evaluate our setup, because the regions will take over and they will actually try to see which of these patient groups should continue having whole genome sequences as part of their treatment. And we do it both on the, of course, number enrolled in each of the group, as well as the process time, because there will also be something about process time when you need to feed back answers to the patients. And then there are literature review, and we are very happy of the literature coming out. There's a huge publication from Genomics England that also says that it benefits rare diseases, so those, of course, will be implemented also afterwards. But then we look into the international experience in national setups that do implementation directly into healthcare. And this has mainly been, at the moment, Genomics England, it's been Sweden, and it has been France. France has a similar, I have heard you work pretty much together with them, and their initiative actually pretty much the same as in Denmark. We also try to get use cases out, like the one with Tony, in order to explain how this works, both for the politician but also for the public and the patients. But of course we also need to make sure to tell them that it's not all whole genome sequences that will come a positive answer that can actually change the treatment. We have semi-structured interviews with the clinicians in order to figuring out how is it actually working with this, both in terms of getting consent, because all Danish patients that will have a whole genome sequences done will make a consent, and that they will also consent whether they will participate in research as well. So we keep the data, and we have the clinicians have the consent, but we know it. So if a researcher should come up and say, I need this many patients, it will only be patient consenting to participating. Follow-up research is of course important, and I hope it will be gathered here in the future. But we are discussing at the moment, it will not be so easy from the healthcare system in order to actually figuring out how to implement. And that's also why I think it was, I'm not an expert in German, but I understand. But I think it will be very interesting also to follow how you are actually doing it. Because I think, like also Richard said, it's important, of course, to see how other countries do it, but it's, of course, also very important to figure out how will it be at the national level. Do you have the experts? Do you have the setup? Do you have the organization? And how can you actually prioritize that? So that's an ongoing discussion here the next year until they take over. And then, of course, it's not only about gathering whole genome data, it's actually using the genome data so they can use both for treatment of patients across Denmark if they should be sick again or one wants to look into the data already there, and then for researchers as well. And then, of course, our goal is that we will also be able to merge these genome data to other healthcare data. And then, of course, international collaborations are important, that we already heard, both from you and from Richard. And that is, of course, because rare diseases are rare, and they are also rare in a small country like Denmark. Access to the genome database is possible, and you can get that if you are working within the area of personalized medicine, and if you have approved Danish Ethical Committee. Approved, the project is approved. If you are a company or you are researchers, for example, from Germany, you can get access if you work together with a Danish researcher. So that's why you can actually get access to the data. Then again, international collaborations are important. Like Richard said, we have the same picture here, Richard. We're signing the Memorandum of Understanding that we also have with Sweden and one on the way with Genomics England. We also hope we will have one with you, but we'll discuss that later. And then, of course, working into the European infrastructure on how can we actually exchange information on data and still, using the laws of the country. So I think that's important. There are several things that we are discussing, and I won't borrow you with that. But I heard you had something about economics. How should you actually do that? How will you calculate the economics? How will you calculate the effect? What kind of data should you actually store for the future? Because the storage of data is also an enormous cost. So what we're discussing at the moment, what kind of files, so what can you actually access afterwards? So these are just some of the points that we are discussing together with other countries. And of course, precision medicine is not only genomes, it's a lot more. It's been there for a long time, and we need to work together, and we need to couple these data with other data in order to actually arrange future healthcare. Because I think precision medicine, I think use of genes is part of future healthcare. Of course, it's not the whole story, but I think it will be part of it because we need to spend time on treating patients that can actually benefit from the treatment and save patients for having medicine that doesn't work. So I think these are one of the important topics for moving this field forward. So thank you for our patience and for our collaborators, both nationally and international, and thank you for the invitation. Thank you very much.